Good morning, and thank you for that kind introduction, and thank you for inviting me to this health promotion conference. It's something that is very close to my interest in addiction and addiction treatment and addiction policy. And the organizers of this conference gave me a somewhat impossible task of summarizing everything I know about treatment and prevention and policy in 29 minutes. So I will try to do that because it forced me to think out of the traditional categories of drug policy and alcohol policy and tobacco and gambling and things like that. We're talking about addictive behaviors which can capture a person's behavior and direct it in a direction which is not good for their health. So what are the priorities of public health for Estonia? Looking at your plan of action, your national health plan for 2020 to 2030, it was interesting for me to find a list of things that Estonia considered to be high priorities, and that is increasing life expectancy for males and females, reducing health inequalities between genders and regions and people with different levels of education and socioeconomic status, expanding the revenue base for the health system, better management of non-communicable diseases, and reaping the benefits of e-health technology, presumably to make technology a way of reducing the expense of healthcare. And looking at what we know about policies that deal with addictive behaviors at a national level, it seemed to me that we know enough from the research that's been conducted around the world over the years that almost every one of these priorities for health promotion in Estonia could be met partially by dealing with the addiction problems that you have in this country by basing your policies on the evidence of different types of policies and interventions that are known to be effective, plus improvements in your treatment system. So that's what I'm going to talk about today. What would be the rationale for Estonian health promotion to meet your global health priorities with the help of what we can do in the area of addiction? Why are treatment services for addiction important for public health in Estonia is the basic question here. Alcohol, smoking, drug abuse, along with gambling addiction, are very prevalent in Estonia compared to other EU countries. And the EU, as we know, has some of the highest prevalence rates of different types of behavioral and pharmacological addictions in the world. We know for Estonia that alcohol-related mortality is one of the highest in Europe, which may explain the differences in life expectancy between males and females. Injection drug use, HIV infection, overdose mortality are among the highest in the EU countries, above average. So here's another area where we could realize important improvements in the health of the population if we could apply the knowledge that we now have at our disposal. So these are questions that we want to answer and apply in the future of health policy in Estonia. But there's a problem. And if we're just focusing on treatment services, we know that there's a dilemma. We have effective treatments for opioid addiction, alcohol dependence, nicotine dependence, pathological gambling, behavioral internet addictions. We have solutions for these problems, and treatment can make a difference. But the dilemma is that a very low proportion of people who can benefit from addiction treatment either do not have access to it, or even if they have access to it, they feel it is stigmatizing to seek treatment. When I was coming in from the airport the day before yesterday, I was talking to the taxi driver, and I mentioned I was coming to a health promotion conference, and he said, yes, I've had an alcohol problem for a long time. 35 years old. He said that, I said, what did you do to solve your problem? And he said, I stopped drinking a couple of years ago, but it was very difficult. And I said, did you get treatment? And he said, no, but I treated myself. And apparently, he didn't tell me exactly what he did, but it sounded like he was ordering disulfiram through the internet and taking it himself. And whenever he ran out of disulfiram, which, as many of you know, is a substance, a drug, which produces an acetaldehyde reaction when people drink. So if you take it in the morning, you're protected during the day. And when he ran out, he would relapse. And finally, he decided that he would stop on his own, and he mentioned the cost of how much alcohol costs to him and his family. He mentioned the negative effects it had on his health, and the fact that he didn't want treatment, but he could find something that helped him. All of this, I think, is useful. This is a useful example of what we're facing. And there's a need to destigmatize treatment, make it more available, less costly, and a better alternative to drinking. But the treatment coverage dilemma persists, and very few people who have problems with addiction actually seek treatment. So the statistics vary from one country to another, but they are definitely indicative of a big gap between the people with the problem and the services that we need. And we undoubtedly can do a much better job of redesigning our treatment service system to take into account the accessibility problems, the perceptions of stigma, and how people can get the types of interventions that they need. So, can improved addiction services in Estonia reach your public health objectives? Well, that's going to depend on whether or not our treatment services for opioid addiction, pathological gambling, cannabis dependence, whether those services are effective enough to add up to the level where they affect life expectancy and death rates at a national level. So the first thing we need to answer is treatment sufficient to have a population impact? The second question is, can we improve our services and integrate them better and create economies of scale across different addictive disorders in order to improve the efficiency and the effectiveness of the services that we make available to people? And the third thing that's going to affect the public health effects or impact of our services is whether or not we can take advantage of a more comprehensive approach than just focusing on treatment alone, but combining that with different interventions to control the supply and availability of these substances, to change people's attitudes towards towards substance use and to reduce the demand and the harm connected with these. So what is the scientific evidence? Well, in fact, over the past 50 years, we've made tremendous progress, not only in evaluating the effectiveness and even the population impact of combined treatment services, but we've made tremendous progress in understanding what the major drivers of health promotion are at the population level. And I'm going to share some of that information that's summarized in the book here in the book Alcohol, No Ordinary Commodity. In the area of alcohol treatment, early intervention and referral to treatment have been evaluated systematically throughout different countries in the world and have produced rather consistent findings that have been summarized in what is called systematic reviews and meta-analyses. And when you pull together all of these studies and you look at the effectiveness of the studies that have been conducted and the breadth of research support, we now know that brief interventions at a primary care level for hazardous and harmful drinkers can reduce significantly a patient's drinking behavior when the health care providers are delivering an intervention combined with screening that fits the severity of their alcohol problem. We also know that referral to treatment for people who are dependent on alcohol begins with detoxification. And we have good evidence of ways to promote rapid de-addiction through detoxification. And we have good pharmacological treatments for alcohol dependence now. We have behavioral treatments one of them is called contingency management, where patients are monitored for their blood alcohol level when they come to outpatient treatment, and they're rewarded if they have a negative or a zero blood alcohol level, and they don't get rewarded if they've been drinking. And contingency management is a good way of getting people to continue in treatment and to motivate them to be sober. We have psychological and social treatments which are effective, particularly behavioral, cognitive behavioral treatments that can produce temporary abstinence and often long-term abstinence. We have self-help groups and self-help organizations of recovering people that can provide support after a person goes through formal treatment, which can be a powerful support mechanism for treatment. And when you put all of these things together, including mandatory treatment for people who are involved in the criminal justice system, we begin to see the elements of a system of treatment services, which can be integrated with the available services for mental health, criminal justice, and primary care and hospital care, which can improve the efficiency and the effectiveness of treatment. We also have good treatments now that are supported by systematic research for drug use disorders. Opioid substitution treatment services, buprenorphine and methadone maintenance are very effective not only in reducing drug use itself, but also crime and the spread of HIV infection. And we have harm reduction programs, needle exchange, and ways of bringing people into the umbrella of our health services system. So even though it looks like it's almost permissive to allow or to condone treatment, we're meeting people in the community, on the streets, where they are, and engaging with them. And what we found in countries like Canada, where these programs, harm reduction programs, have been experimented with, is that there's good evidence that you can engage people in seeking further treatment just by providing preventive measures in harm reduction programs. Cognitive behavioral therapy for cannabis dependence is another way that we can provide outpatient services for people who do not want to go into a detoxification facility or even into a long-term inpatient program. And we did a study in the United States in 3 cities with 450 chronic marijuana users who were recruited into a program where they could receive treatment. They were very willing to come in for confidential treatment because nothing was available at the time, and they were at the point in their careers, their drug use careers, using cannabis daily for 15 years on average, that they were ready to stop, but they couldn't do it on their own. We had one group, which is a waiting list control group, another group that received 2 sessions of motivational enhancement therapy with a trained therapist, and another group that received 9 sessions. And you can see here the improvements from 90% days using marijuana down to about 30% in the group that had 9 sessions. Another interesting finding in this study is that the group that reduced their marijuana use the most and maintained that reduction over the course of 15 months was able to reduce their cannabis use significantly after right at the beginning of their treatment, before they even ended their treatment. So what that suggested is that the anticipation of access to continued treatment up to 9 sessions was enough to motivate them to stay away from cannabis use. And they were able to show significantly better improvement. So, do these types of interventions add up to a reduction at the population level in HIV rates, in opioid overdoses, in alcohol cirrhosis of the liver, in cannabis addiction? The question is important because we want to go beyond just providing humanitarian care to people who deserve it within our healthcare system. We want to answer the question, is treatment sufficient? And so we need a model of our treatment services. And this one talks about addiction services in terms of a variety of components which could add up to a population level impact in improved life expectancy and improved health. The first component is treatment policies. We need better planning, we need financing, we need monitoring, and we need collaboration with the criminal justice system, with mental health and social services. Those ingredients, those policies for treatment provide us with facilities and programs and personnel to build a more effective treatment service portfolio to deal with the population needs. But within the system that we build, it's also important to improve accessibility, because we know not everyone is going to take advantage of the treatment services because of the stigma associated with them. We need to integrate those services better so we can provide economies of scale and greater, more efficient management of detoxification and early identification, referral to treatment, mental health. If we could combine these in the way that they're delivered through better training of our personnel, through better access to these treatments in one-stop shopping where patients come to a particular service provider, that should improve the overall effectiveness of the treatment system. And finally, a lot depends on the characteristics of the patients or the clients themselves, whether they're younger or older, whether they are a lower socioeconomic status or higher socioeconomic status, rural or urban. All of these factors affect the ability of our treatment system to have an impact at the population level. There's some research that shows that the more services that are provided for people with alcohol dependence, the lower the cirrhosis mortality rate at a population level. That is encouraging research, but it's an observational study, and there hasn't been much research, more research on this topic. Increases in the attendance of Alcoholics Anonymous or other self-help groups. When those types of support groups are more available, we can also observe decreases in cirrhosis mortality. And we've seen some success stories in countries like France, the UK, Norway, the USA, when treatment for people with opioid dependence, especially making more available opioid substitution therapy, can have an impact on HIV rates and crime and opioid overdose. So there is suggestive evidence that we can have an impact at the population level by making treatment services more available, but they're very expensive and not everyone is going to use them. Modeling studies also suggest that when you project what the studies say about the impact of a particular type of therapy, and you add up all the therapists that are available to deliver it, and you see where it can be delivered, you can estimate by increasing the availability of certain treatment services, you can have an impact at the population level. So, do treatment and early intervention have an impact at the population level? Well, the answer is not yes or no. It's partially true. It hasn't been verified enough by research to tell us that it's going to make a difference, but the evidence is suggestive, and what we are learning is that treatment is going to be only one component of a broader set of policies that will deal with the addiction problem in a particular country, in a municipality, at a population level. So let's talk about universal strategies. We're talking about strategies that can be implemented from the top down by changes in accessibility, in attractiveness, and the cost of different addictive substances, including gambling. How can treatment services be strengthened to have a population impact? Well, universal screening and brief intervention in healthcare is one thing we could do more of. And by doing that, we are not only dealing with people at the primary care level where there's a less stigmatizing environment for patients to come to, but we're also in a position to refer people motivate them to seek more formal treatment if the screening tests indicate that they are at a level where they need detoxification and outpatient or inpatient treatment. So universal screening is one solution. Another is the use of e-health technology. You can do the screening online. You can even deliver brief interventions and cognitive behavioral therapy online, and the research suggests that the effects are just the same as doing those types of interventions in person. We can improve the efficiency and the economy and the effectiveness and continuity of care of our treatment services. We can put into effect marketing bans because there's a good literature on how marketing not only affects young people, but, for example, tobacco and alcohol marketing affect people who have developed dependence on these substances. And people with alcohol and nicotine dependence react very differently through their autonomic nervous systems and the brain neurotransmitters when they see stimuli that look just like the kinds of stimuli we see in alcohol marketing messages and visual images. So banning marketing might help to reduce relapse among people who are trying to remain sober. Enforcement of drink driving laws are a way of engaging more people in treatment. And dedicated alcohol taxes can fund our prevention and medical services. So we have a variety of things that can be done to improve our ability to achieve those population goals. But we need to do a better job of advocating not only for more treatment services, but for advocating the upstream policies that are going to complement our treatment services, including integrating our services better with criminal justice and with primary care and hospital care and mental health services. We know that it's more efficient because people with one type of addiction problem, whether it's smoking or drinking or drug use, tend to have another one. So multiple types of substance use are now the norm in most countries. And we've seen that brief interventions that can be used in conjunction with a screening test. Here we have a study that was sponsored by the World Health Organization in 4 countries, India, Australia, the USA, and Thailand, where people were screened in primary care settings for tobacco, alcohol, and other substances. And they got a score not just for each substance, but for all of the substances involved. So their substance involvement became what their addictive disorders was. And in those cases, if the patient got a brief intervention, one or two sessions with a primary care doctor or a nurse, we saw a small but statistically significant and meaningful, clinically meaningful improvement in the reduction in their substance use or substance involvement. So, what are the advantages of looking upstream? Well, we know that most of our cost for providing addiction services is down at the bottom when people have fallen into the river and have been rescued before they died downstream. And we've seen enough of that to raise the question of what's happening upstream that is pushing those people into these addictive problems. And what seems to be the upstream sources of damage, according to availability theory, is affordable prices, cheap alcohol, cheap drugs, We've seen what happens with cigarettes and nicotine when we raise the prices. So we know affordable prices make a difference, and when we increase the taxes, we can have an impact. Easy availability and convenience. The more affordable these substances are, and the more accessible they are, the more convenient they are, which is a quick answer to the question about cannabis legalization. Legalization is likely not only to increase physical availability, it's likely to increase psychological availability. And people think that maybe this is more normal than it used to be. And that should lead to an increase, which we're observing in some countries that are now liberalizing these policies. We don't want a culture that normalizes drinking and smoking and gambling. And aggressive marketing, by banning that, is a way of reducing the perception that substance use is normal. And when you legalize cannabis, for example, you get the profit motive that comes in where in a licensing system, people are promoting the use of that substance one way or the other to make a profit. And also the lack of regulatory controls is pushing people into that river. And the lack of regulatory controls is not only in countries that have no controls, it's in countries that have controls like Finland that are now debating reducing regulations that have been effective for years. So we've got a lot of initiatives that have been shown to be effective. The SAFER initiative, the Best Buys promoted by the World Health Organization for alcohol are both downstream and upstream, but the Best Buys are increasing excise taxes and minimum unit pricing to reduce the attractiveness of cheap alcohol, restrictions on alcohol availability, and bans on marketing. We've seen how this works in the Baltic states, in Lithuania recently. We've seen how it works in the Nordic countries, Finland, Norway, and Sweden, whose policies have been implemented by taking advantage of what we know about the beneficial effects of higher excise taxes, restrictions on the availability, physical availability of alcohol, and bans on marketing. In Lithuania, when an increase in the taxation on wine and spirits was implemented several years ago, we saw not only a reduction in alcohol-related mortality, but we saw a rapid increase in revenues that went into the healthcare system. So this is considered a Best Buy by the World Health Organization. In the United States, increased taxation in the state of Alaska in 2002, and again 15 or 20 years later, led to immediate reductions in alcohol-related mortality. And in the state of Illinois, again, a tax increase led to a reduction in fatal alcohol-related motor vehicle accidents. So how can upstream measures improve treatment effectiveness? Well, for alcohol use disorders, taxing can make, as my taxi driver explained, the cost of treatment prohibitive for people who then reduce their alcohol consumption or stop drinking. Physical availability controls can reduce the convenience, marketing controls can reduce the attractiveness, and drink driving policies can get more people into treatment. So we have a lot of evidence-based interventions for alcohol and other substances that are effective. What is much more difficult is that when a substance is illegal, like certain types of illegal drugs, alternative development, interdiction, enforcement, punishment have minimal effects. From what we can see, and this is very difficult to study, but from what we can see from the research, they have not made a major change. They can interrupt the supply chain, increase the cost, and have an impact, but unfortunately, they do not solve the problem. We need both treatment and more effective policies. In the case of Norway, gambling policies at stations where people could access electronic gambling machines, there was a ban put into effect. And first, they banned banknote acceptances, so people couldn't use their credit cards. They banned night opening or access to the gambling machines. And they then banned all electronic gambling machines for about a year when they were replacing them with a new form of less addictive gambling machines. And the effects were somewhat dramatic. There were sharp reductions after each intervention was introduced. So what can we learn from all of this? Well, in our service system, flexibility is very important because the situation in 2 years, in 5 years from now, could be completely different with new technologies like vaping coming into effect, new drugs, new problems. But we need to be flexible within our treatment service system. We need to integrate better with primary care, criminal justice, and mental health care, coordinate needs-based planning, doing surveys of the population to find out who's using these substances, what their service needs are, and then redesigning our service system to be more efficient at reaching them and satisfying their treatment needs. And most of all, we need better workforce training, innovations, training, workshops, as well as universal policy measures. So can public health approach that includes the WHO Safer Initiative, Best Buys, help to meet national health plan priorities for Estonia? I think we can answer all of those priorities, yes. It's not going to solve all of your health problems in the country, but it could have a significant impact, as we've seen in Lithuania and other countries where we can see improvements in life expectancy through a combination of better services and upstream interventions. So the conclusion is that policymakers really want to know, is treatment effective? The answer to that is yes. But they want to also know, is it going to affect crime rates, HIV, life expectancy, non-communicable diseases? The answer is that treatment is probably not sufficient. It needs to be combined with upstream measures. And if you want to get more information about any of the things I've been talking about, I've been working over the years with a group of social epidemiologists and psychiatrists and people who have put together book summaries, some of them sponsored by the World Health Organization, on drug policy, alcohol policy, and gambling policies. And there are summaries in the journal Addiction, an international journal, of each of these books that can be downloaded for free, or you can write to me and I can send them to you. And Alcohol, No Ordinary Commodity is available online as a free download from Oxford University Press. So thank you again for inviting me. I wish you good luck in the remainder of your program today, but more importantly, let's be optimistic about our ability to deal with these addiction problems at a population level. Thank you.
Thank you so much, and please don't leave yet. We have several questions. Unfortunately, we have time to squeeze in only one of them, but this was the first one and is one of the most popular ones that people want to ask. I would say an internal prioritization question. The resource is always limited, whether it be finances or human resources specialist time. What would you recommend to Estonia to prioritize? Whether preventive interventions targeted primarily at children or youth, or treatments, early intervention treatments for addictions. What is your advice?
Well, I'm going to ignore the question a little bit by saying the two-word answer, where you could have both, is health taxes. And if we could increase taxes on alcohol and tobacco, and find a way to channel that money into the healthcare system, we would have the best of both worlds, because we could provide more preventive and health promotion services and more treatment services. And the World Health Organization has just published a book called Health Taxes, which explain how you would be able to accomplish these goals through uses of the health tax strategy to finance the health system to get us towards universal health care, but better services for alcohol and drugs.
Thank you. It is obvious that this was not the first time you have been asked this question.
Right.
Thank you so much.
All right, thank you.
Meil on tulnud küsimusi.
We have questions, but I would like to take the opportunity. Thomas Barber is in the hall, so I will ask him instead.
Why do people consume alcohol? What are the root causes? No, just from the spot, yeah.
Okay. So, why do people drink? I think the short answer is short-term positive brain reinforcement. If you look at the blood alcohol curve, when you take 1 or 2 drinks, the alcohol is going to your brain. When your blood alcohol level is going up, people report euphoria and stimulation. And that is a reflection of what's going on in your brain, which is brain reinforcement, dopamine. And when your blood alcohol level is coming down, people feel tired, depressed, fatigued. And short-term positive reinforcement is always better in terms of motivation than long-term negative reinforcement. So the short answer is brain reinforcement, stimulation. People like the pleasure that they get from alcohol, from cannabis, from opioids, but the delayed negative effects only come later, and a lot of our behavior is controlled by short-term positive reinforcement.
So the trick would be that we would need to learn how to get the positive reinforcement from some other source, from some other behaviors.
That is one possibility, preferably not pharmacological in nature. But yes, you can get similar changes in your neurotransmitters from a variety of things like exercise and just watching a movie or something like that. So yes, but alcohol is a powerful drug, and so are opioids. And it's difficult once people become conditioned to using it, their brain becomes conditioned, and then it's difficult to stop.
Thank you.